next speaker, my colleague Sanil Joseph. Here he is. Good. So he has been working in Lyco Aravind for more than 20 years. And most of his work happens to be in the area of research. Within Aravind, he leads the research portfolio and manages the biostats and so on. And he has been having an interest in technology, specifically relating to diabetic retinopathy for quite some time. So it is only appropriate that he's going to be talking about effectiveness and feasibility of AI-based automated system for detection of diabetic retinopathy in primary care and endocrinology settings in Australia, where he has been there for the last 3+ years. And I believe this is in the real world setting, right? Yeah. On to you, Sanil.
Thank you, sir. Good afternoon, everyone. So this is a pragmatic trial that we did in Australia as part of. Oh, sorry. As part of the graduate research program I was doing at the University of Melbourne's Centre for Eye Research, Australia. So just quickly flipping through the background. So diabetic retinopathy is a leading cause of preventable blindness, as all of us know. And the DR prevalence among people with diabetes in Australia ranges from 25 to 32%, of which the vision-threatening DR is approximately 4.5%. And many remain undiagnosed, as we know, because it is asymptomatic at its early stages. And hence early detection is essential. And the current screening models based on retinal imaging has challenges because it requires a technically trained person to capture the image at the first place, and it needs the images need to be interpreted by a specialist, and that poses a challenge in replicating this in many settings. So, Center for Eye Research Australia came up with an AI initiative for DR screening, characterized by a fully automated system for retinal imaging and grading. So it enables opportunistic screening of in general practice and endocrinology clinics, where you can find diabetic patients more than in an eye care setting. And it reduces the reliance on technicians and eye care professionals because it is completely automated, and thereby trying to address the existing gaps of low screening uptake and delayed interpretation. So the purpose of the study was to investigate the diagnostic accuracy, feasibility, and end-user experience of this system in a real-world primary care endocrinology clinic settings in Australia, because the system has already been validated, and so internal and external validations were done. So we just wanted to field test it and see how feasible it is in the real world. And we included 5 study sites, 2 general practices from the state of Victoria, 2 endocrinology practices from the state of Victoria, and an Aboriginal medical service in the state of Western Australia. So the screening system we used 2 different modes. One based on a larger, sorry. Sorry, I should stick to the laptop. Yeah. Yeah. So the bigger system is a kiosk-based system where, as you can see, the patient can sit and place their eyes, and it will give a audio prompt because it is full of sensors, so you can guide the patient. It will guide the patient to move their forehead or place the eyes correctly, and the fundus camera gets automatically focused and captures the image because it doesn't need a technician to manually capture the image, and the immediate interpretation is given by the integrated AI algorithm, which generates a QR code which can be scanned by your mobile device, and it brings a report onto your device, including the image, the DR grading, and the referral recommendation. And the patients are referred if there is a positive finding. And the retinal images were subsequently human graded just to create the ground truth. And the mean age of the participants was 62.6 with a standard deviation of 13.2, and 53% were women. And we enrolled 863 patients, and we could successfully capture images from close to 76%, and 12.7% were ungradable images due to various reasons. And the system referred 36% of the patients who are more than mild diabetic retinopathy, or when the images were ungradable. And they were followed up in 3 months. We could reach about 77% of the people either through phone or email. And of the people who we could reach, 47.5% had actually complied with the referral. And we looked at the accuracy compared to the human grading, and these are the accuracy parameters. We had close to 84% sensitivity and more than 96% specificity. And in the 5 sites, the last site was we tried a different inclusion criteria. In all the other sites, we recruited everybody above the age of 50, and those above the age of 18 when they are diagnosed with diabetes. But in this particular site, we wanted to see if there is a difference if we include people with more severe and prolonged diabetes. So we recruited only patients with confirmed diabetes with a HbA1c level more than 9, so that we ensure that they had severe levels of diabetes. And we could see that the sensitivity was much higher in that particular group. So the proportion of people with diabetes in the rest of the cohort was 47%, close to 47%, whereas in the group B clinic it was 100%. So there is better accuracy among patients with severe and prolonged diabetes. And we did the patient satisfaction survey. 73% of the patients were satisfied with the automated DR screening, and 13% were neutral. And 86% of the patients said the screening system was easy to use, and patients recognized the benefits of the system, as 77% patients agreed that they would reuse the system, and 78% would recommend the screening to friends and family. And 43% of the patients said they would prefer not to pay out of pocket for this facility. And of those who agreed to, those who were willing to pay, 26% majority, that was the majority, they were willing to pay 11 to 50 Australian dollars. And we also interviewed the care providers, who included the physicians, the clinical staff, and the practice managers of the clinics. And overall, 76.2% were satisfied with the AI-based eye care, the eye screening system. And they found the system is very convenient, as 76% felt that the reports generated is easily explicable, and felt that underlying AI technology and the approach was clear and easily explainable to the patients. And the presence of AI system was seen as beneficial by 85% of the providers who felt it improved their ability to conduct eye screening, and would recommend it to their patients. And so to conclude, AI-based DR screening system is both effective and feasible in non-eye care settings in Australia. And with the high diagnostic accuracy, the AI system enables early detection of referable DR and addresses gaps in accessibility and early detection. And positive feedback from both patients and the care providers supports its integration into routine clinical practice. And this highlights a strong potential for broader implementation to prevent vision loss due to DR on a larger scale. And the lessons we learned out of the challenges we faced is, one is the AI-based screening adds greater value in non-eye care settings because it doesn't add any waiting time. It's an opportunistic screening model. We captured the image while the patients waited for their appointments. That is very convenient to the patient. And the support from the GPs and the general practitioners and the endocrinologists is critical for patient acceptance, because not all the GPs or the physicians were with us. So some were not very confident about the system. So we could do only when people agreed to do that. So their acceptance is very important in integrating this in regular caregiving process. And the portable modality proved to be more effective than the kiosk, and patient willingness to pay still remains a barrier. And in terms of a novel methodology, it is a fully automated device and reduces reliance on specialists. It can be there is better acceptance in non-eye care settings, and screening using a portable device allows us to do this even in outreach settings, and there is enough memory capacity to store the images that one can capture in a couple of days. So even if you are not connected, you can take it back and get it evaluated later. And finally, in terms of translating this, the plan is to advocate with the government to include this in the Medicare, in the state supported healthcare program, and secure a medical benefit schedule number so that it can be reimbursed to the practitioners, and the deployment and testing across populations to make sure that we refine it to different populations and ethnicities. Thank you very much.
I guess my question is actually about the follow-up of the patient. So if there's diabetic retinopathy that's referable, detected by the AI, then it goes off to an ophthalmologist for care. But if the patient is screened and they have no diabetic retinopathy, is there then, worked into a system, some sort of a recall follow-up for the patient, because they will still need regular eye examinations?
Yeah, so we didn't. So thanks for that question. So we didn't do anything actively in the study, but that is what we are proposing in the model when it is being integrated to the routine practice, because it's with the GPs, so they will know their patients and they will have a record in the practices.